All right. Good morning, everyone. Thank you for joining us and welcome to our October NCAS webinar on the theme of audit and feedback. We're super excited to have two fantastic presenters today, Professor Denise O'Connor and Alainah Oats. So just a few housekeeping things to begin with. The session will be recorded and we'll pop it up on the NCAS website after the session. If you've got any questions, if you can pop them into the Q&A section at the bottom of the screen, or if you've got something that you actually want to talk to, then just let us know, either raise a comment or raise your hand and we can unmute you and you can talk live. We will have time for, we'll do a combined question and answer towards the end of the presentation. We should hopefully have around about 10 minutes to talk through some of the themes that have been discussed today. So our first presenter is Professor Denise O'Connor. Denise O'Connor, she's an Australian NHMRC Investigator Leadership Fellow and Deputy Director of the Wiser Healthcare Unit in the School of Public Health and Preventive Medicine at Monash University. She's a world-leading expert in implementation science, and she collaborates with health agencies and consumers to design and evaluate solutions to improve value in healthcare for Australians. She's conducting implementation research across 3 NHMRC Centres for Research Excellence, one of which is, of course, our NCAS, Antimicrobial Stewardship across One Health, CRE, but also Wiser Healthcare and the Australia and New Zealand Musculoskeletal Clinical Trials Network. Thank you so much, Denise.
Thank you, Caroline, for that introduction, and it's great to be speaking with you all today. I'll just share my slides. And can you see those okay?
Yep, looks perfect.
Fantastic. All right. So as mentioned, thanks for the opportunity to present this morning on the evidence that supports audit and feedback in antimicrobial prescribing and stewardship. And I acknowledge the traditional owners and pay my respects to their elders past and present and to First Nations Australians who may be here today. So I just want to start with an operational definition of audit and feedback and then describe how it's theorised to work. Then I'm going to go on and present an overview of our recent Cochrane review of audit and feedback trials that covers all healthcare settings and clinical topics, and then drill down to audit and feedback targeting antimicrobial prescribing and wrap up with some take-home messages. So I don't need to convince this audience. Antimicrobial resistance is now recognised as one of the leading global health threats, and governments and entities in Australia and across the globe have called for urgent action to curb overuse and misuse of antimicrobials across One Health. And of course, we have the Centre of Research Excellence here in Australia focused on this, and other researchers across the globe doing similar work. So antimicrobial stewardship programs are a key approach for improving antimicrobial appropriate prescribing, and audit and feedback is an essential or core element of such programs. So audit and feedback involves measuring clinical performance over a specific period of time, that is the audit, and then comparing the performance to evidence-based targets or peers, and then providing a summary of this data to healthcare individuals, teams, and or organisations with the aim of improving patient care and outcomes. We know that audit and feedback draws on multiple behavioural theories, and these describe how individuals are prompted to modify their behaviour when they're given data, performance data, showing how they're performing and that it is inconsistent with a desirable target. And some of the examples of these theories include, that you may have heard of, include social comparison theory, where people where we evaluate ourselves by comparing to others, and also cognitive dissonance theory, where we feel uncomfortable or discomfort when we learn that there's an inconsistency between our beliefs and our actual behaviour, and that is meant to in turn motivate behaviour. So several of these theories have been somewhat criticised for focusing on only part of the feedback process, or missing potentially important components or factors specific to healthcare that can influence feedback effectiveness. And so Ben Brown and colleagues, you can see Ben pictured there, developed the clinical performance feedback intervention theory a few years ago. And this very much builds on previous behavioural theories relevant to audit and feedback. And it also incorporates a synthesis of qualitative studies relevant to audit and feedback and how it is thought to work. So this theory proposes, I'll explain the cycle, that effective feedback works in a cycle first by selecting best practice standards or targets against which care is measured, and this is that goal setting process. And that's followed by a collection and analysis of performance data against these standards or targets. And a summary of this performance is fed to healthcare providers, who ideally engage with that feedback and then interpret the data, and they may undertake a further step of verifying it to check that it's accurate before accepting it. This then leads to an intention towards an actual behaviour change and ideally performance improvement, and then recipients continue around the cycle again with repeated feedback. Now, it's possible that there is positive or negative unintended consequences, and this may influence progress around the cycle, and also recipients may disengage if they reject the feedback and hence not continue around that cycle. So the other thing that the new feature of this CP-FIT theory, building upon other prior theories, is that it proposes that progress around the cycle is also influenced by these other variables. So feedback related factors, so things like the perceived importance of the audit goal, how feedback is displayed, as well as how it is delivered to recipients. Secondly, recipient related factors such as clinicians' knowledge, skills and attitudes, as well as contextual factors, so the context in which those clinicians work, what's their organisational leadership like and culture, what is the infrastructure and resources in place to support use and uptake of that feedback. Are there co-interventions that amplify the effect of feedback, and what are the processes used to support feedback use? So that is how audit and feedback is theorised to work, and the best theory at the moment, or the most comprehensive theory that we understand in relation to this process. But what about the effects of audit and feedback on professional practice in general? Some of you may be familiar with Noah Ivers. So he is a family doctor and researcher from Toronto, and he's led 2 of the Cochrane reviews of audit and feedback, one published about a decade ago, and then one conducted with colleagues and I and published earlier this year. And as you can see from the slide, this update contains now 292 randomised trials of audit and feedback across any healthcare setting and clinical topic. And as such, I think is the largest systematic review of quality improvement interventions to date. And since the last Cochrane review was published, you can see that 152 new trials have been added. So what does this tell us? Well, this is a summary of findings table from the review. It's sort of the most important take-home message from the review. And this shows that meta-analysis of data that could be pulled from 177 of these trials and almost 19,000 clusters of health professionals shows that audit and feedback with or without co-interventions probably leads to a 6.2% increase in desired practice on average compared with control. And that evidence is graded as moderate certainty evidence. It means that we think it's likely to be accurate, but there was quite a bit of variation in results across the study, so hence the certainty of the evidence was downgraded one level. Now this figure shows the pooled results from the meta-analysis, and you can see, I'll draw your attention to the blue diamond. So that represents the pooled effect estimate and the 95% confidence interval, illustrated by the width of the diamond, as well as the median and interquartile range of effects shown by the pink box plot at the bottom. And it also displays the individual study effects shown by the bubbles, the distribution of these. And I guess the point to take home from this slide is that while on average, audit and feedback probably leads to modest improvements in desired practice compared to control, you can see that there's substantial variation in the effects across these studies, with about a quarter of the studies that you can see here falling on that dotted vertical line or to the left of the line, and they show no benefit or worse performance with audit and feedback. And so that means that audit and feedback isn't benign, and we need to actually design and deliver audit and feedback interventions thoughtfully and learn from previous studies so that we obtain benefit with audit and feedback interventions. This distribution also shows that about a quarter of studies lead to fairly large improvements in practice. And so what we want to do as developers and researchers is actually replicate those studies with the larger effects and predict in what situations the larger effects will occur so that we can direct feedback to where we think it will be maximally effective. So just going back to the summary of findings table, I want to just draw your attention to the effects in a couple of pre-specified subgroups that's obviously relevant to what we're talking about today. And the review found that the pooled effect for prescribing, which represented about half of the studies, had similar effects compared to studies focused on test ordering. And you can see that there for prescribing, audit and feedback led to 6.1% increase in desired practice, and test ordering led to, on average, 5% increase in desired practice. So they're pretty similar. The other thing is that many of the trials included in this review deployed and investigated audit and feedback as part of a multi-component intervention. So typically audit and feedback was delivered with education as a co-intervention, or reminders, or patient-mediated interventions. And the median of co-interventions was 2. And so this figure simply shows that trials with more co-interventions have slightly larger effects. However, we're uncertain which co-interventions work best to amplify audit and feedback effects, and so more work needs to be done on that. But as mentioned, the most typical co-interventions were education reminders and patient information or patient-mediated interventions. So if we know that audit and feedback can work and that can lead to modest improvements in desired practice, then we really want to know what are the characteristics that are likely to lead to better effects. And so meta-regression of these trials in the review shows that larger effects are associated with specific recipient and intervention characteristics. And that is where baseline performance is low, so there's room for improvement, and as mentioned, where co-interventions are added. But also, the review found that that results are amplified when individual level data is provided rather than team or organisational level data is provided. And this makes sense because if I'm receiving information about my prescribing or test ordering, there's less wiggle room to, say, well, that was Caroline who, is responsible for that. The review also found that feedback delivered by a local champion known to recipients is associated with greater effects. And also when interactive modalities, so verbal as well as written modalities are used, and that is thought to facilitate engagement and uptake of the feedback. And then finally, when action plans are provided with the feedback to support performance improvement. And so these characteristics are likely to be best practice for designing and delivering audit and feedback at the moment. However, you can see on the slide, this was rated as low certainty evidence, and that's because it comes from meta-regressions of those trials or indirect comparisons. So we didn't have head-to-head trials comparing all of these features, and so therefore we need to continue to build that evidence base to actually have more robust data to underpin information about how we can maximise the effects. And just on that point, perhaps surprisingly, the update contained relatively few, actually very few trials of head-to-head comparisons of different ways of designing and delivering feedback. Only 17 trials, or 6%, contained in the review looked at this, and you can see the different variations that were examined in these head-to-head trials shown on the slide. And the bottom line from this is that peer comparisons appear to be better than no peer comparison. And then also incorporating design elements in the feedback that draw recipients' attention to where action is needed is likely to be better and seems very helpful in providing this feedback. So what about audit and feedback for improving antibiotic prescribing? So Alice Zhu and Kevin Schwartz and Noah and other colleagues and I leveraged the data from the Cochrane Review to investigate the effects of audit and feedback on antibiotic prescribing volume and appropriateness. And we identified 56 trials, most of which were from high-income countries, including 3 from Australia. They predominantly targeted prescribing in adult patients and provided predominantly individual level feedback to clinicians on several occasions. And the meta-analysis of this pooled data across the studies showed that on average, audit and feedback probably leads to a 23% relative reduction in inappropriate antibiotic initiation compared to control, and it may lead to an 11% relative reduction in total prescribing volume, 17% reduction in broad spectrum selection, and a 13% reduction in prolonged duration. Now, the certainty of these estimates were downgraded again, due to that inconsistency, a presence of inconsistency that was unexplained across the studies. And then in the latter 3, it was downgraded to low certainty evidence because there was additionally the risk of bias in some of the contributing studies. So it means we think these are pretty good estimates, but obviously some of the latter 3 comparisons could be strengthened by some additional high quality studies. And so what about audit and feedback for improving antibiotic prescribing in hospitals? Well, we think that we know that there's at least 14 randomised trials in this area, 9 of which assess multi-component interventions comprising audit and feedback versus control, and 5 comprising head-to-head comparisons of different ways of providing audit and feedback with or without co-interventions. And one of our PhD candidates, Misha Devshand, in the CRE is conducting a systematic review to synthesise this evidence as well. And this will help us describe studied characteristics, estimate the pooled effect, and also explore factors that may explain variation in results. And finally, I just wanted to show you this. This figure shows the availability of audit and feedback tools over time. And as you can see, this has improved in the last decade, as indicated by the green and blue shading, representing tools available in publications or via contact with the trial authors. But still overall, only 36% of trials actually made the tool accessible, which, is disappointing, but at least it's improving over time. And so in an effort to make these tools more accessible to folk like you, developers and researchers, we've collated these into an online repository of tools organised into 9 categories. And not surprisingly, one of those categories is dedicated towards antibiotics. And so I'm going to leave it to those interested to browse all of the examples, and we're updating these with some trials that are awaiting assessment from the Cochrane Review, with a search conducted up to 2024. So more recent trials and their tools are being added as we speak. But I just want to show you a couple. So here's one trial by Wathney in Norway, and this presents feedback on antibiotic prescribing in hospital settings. And you can see they've used stacked bar charts and pie charts to display that data quickly to end users. Another example by Trent from the US, providing feedback on prescribing for patients with pneumonia and sepsis. An example from Scotland in dental practice, and I think this is the only trial in dentistry and was a landmark trial done about a decade ago. And then finally, one from a colleague in Canada on prescribing of antibiotics and other medicines in long-term care. So obviously there's lots of different ways that this data can be presented, and so hence we think it's a really valuable resource to be able to access and look at these. So in summary, there's a substantial theoretical and empirical evidence base to support use of audit and feedback for improving professional practice. And audit and feedback most often achieves modest improvements in care compared to control, but the results vary across behaviours, settings and designs of interventions. We think that certain intervention characteristics may increase its effectiveness, but we need head-to-head trials of audit and feedback variants to actually confirm what works best, and so that we can predict this in the future. And a meta-analysis of trials of antibiotic prescribing in primary care shows that audit and feedback is effective for improving antimicrobial appropriateness and volume, as well as a review of trials in secondary care is underway as part of this CRE. And finally, we hope that making these tools, audit and feedback tools, easily available may help developers and researchers learn from what's happened before and more efficiently advance the field in the future. Lastly, I just want to flag that we are holding the 10th International Audit and Feedback in Healthcare Conference, which is online in about 3 weeks' time. So on the slide here is your ability to register. So please, I'll share this with Caroline. I'll put it in the chat, and it'd be great if people would like to join this. And we're also holding a satellite in-person event at Monash University School of Public Health and Preventive Medicine on Friday the 7th in the morning. So please get in contact with me, and we'd love to see you at the in-person event. And I'm going to stop there. Thanks so much.
Thank you so much, Denise, for that brilliant presentation. And yes, I'll once the next presentation gets underway, I'll pop the link for those events in the chat so that people can have a look and register if it's of interest to them. So we're going to hold off on any questions for the moment. We'll have a combined Q&A at the end of the session, so after Alainah's presentation. So without much further ado, I'd like to welcome Alainah Oats. So Alainah is the Acting Director of Pharmacy and Senior Clinical Pharmacist at Mount Isa Hospital in far north Queensland. She chairs the AMS Committee for the North West Hospital and Health Service and is really passionate about promoting judicious antimicrobial use while addressing the unique challenges faced in rural settings. Thank you so much, Alainah.
Thank you, Carolyn. I'll just share my slides. Can everyone see that?
It's just coming through. Yep, perfect.
Perfect. All right, so hi everyone, and thank you, Carolyn. As Carolyn mentioned, my name is Alainah, and I'd like to start by thanking ANCAS for the opportunity to discuss audit and feedback from a rural and remote perspective. It's very exciting from a small hospital such as Mount Isa to have the opportunity to present on a national forum such as this and share our learnings and experiences from that remote health service perspective. We do have unique challenges, but I hope that even if you work in a metropolitan area, that you take something away from our practices out here in the bush and at least have some thoughts on how we could grow our feedback methods out here as well. So I'll get stuck into it. First of all, we'll begin by acknowledging the traditional owners of the land on which I present from today, the Kalkadoon people of Northwest Queensland, as well as acknowledge those in the areas you reside on and pay our respects to elders past and present. I would like to begin by introducing you to the Northwest and the Health Service. As you can see from the diagram, the Northwest Hospital and Health Service is that rather large landmass in the upper left corner. The main settlement in this Northwest region is Mount Isa, and Mount Isa has an approximate population of about 18,000 people. In the Northwest, 21.5% of the population identify as Aboriginal or Torres Strait Islander. So we have a really large First Nations population here. The Northwest Hospital and Health Service is comprised of several hospitals and primary health centres. So we have Mount Isa as the largest hospital, but we also have Cloncurry, Domagee, Normanton, Mornington Island, Julia Creek, and they are all quite isolated. We also do have some primary health care clinics which are serviced by our rural blind doctors and also by some nurses there as well. So as you can see, the Northwest is a really large area, but unlike our metropolitan areas in southeast Queensland, we don't really have the same population density, but still is covering quite a large area of Queensland. So now a closer look at Mount Isa Hospital, as this is where we conduct most of our audits and feedback. Mount Isa Hospital comprises of 83 beds and is the main referral site for all healthcare facilities in the Northwest region. We have all the typical inpatient units, so a surgical, medical, an ICU, a paediatric and maternity, special care, an ED, an OT, which provides general surgical procedures, a HD unit and a care unit, plus some outpatient services as well. So now you can likely appreciate we're a small but a mighty health service, and I hope have a better perspective on how just remote we are. For a little bit more context, we're about 10 hours drive from our nearest tertiary hospital, which is Townsville, and a 3-hour flight from Brisbane, which is our largest sort of metropolitan area. So very remote out here, but we still try our best. So this isn't a presentation on AMS. So I also wanted to share the microbial landscape up here for you so you can appreciate what we're dealing with on a daily basis. So in 2024, 40% of our Staph aureus isolated were resistant to flucloxacillin, so really high rates of MRSA. 17% of our E. coli isolates were extended spectrum beta-lactamase producing isolates, and our most common isolate in blood cultures were E. coli. We also have high rates of rheumatic heart fever, rheumatic heart disease, especially in our First Nations population. So that's about 4,000 per 100,000 people in the Northwest region. And on occasion, we actually do see some exciting tropical diseases such as melioidosis during the wet season. But what does our AMS service look like in a rural and remote health service? So we don't have any on-site AMS or ID physicians. We don't have any on-site AMS nurses or a dedicated AMS pharmacist either. Doesn't mean we are neglected. We do have some really excellent support provided virtually from the Queensland statewide AMS program, which is situated in Brisbane. QSAMPs conduct a weekly virtual ward round with us on a Tuesday, and they provide monthly educational events. As mentioned, I'm the chair of the AMS subcommittee here, and that's comprised of a multidisciplinary group of pharmacists, nurses, and medical doctors who support the AMS program with the Executive Director of Medical Services as our sponsor. And the clinicians can also call our tertiary referral site Townsville for ideal AMS advice, and they've also got access to the Queensland Children's Hospital as well if they've got a paediatric patient. So we do have lots of support from other areas, and QSAMPs do conduct a little site visit as well yearly. For our AMS meetings, we have the QSAMPs team that also attend those, but we have that ID representation from one of the physicians and an AMS pharmacist in a CMC. So whilst it's difficult without a dedicated team, we are fortunate to have lots of assistance when needed as well. So moving on to how we actually audit in the Northwest from a NAPS and SNAPS perspective. So we undertake a NAPS yearly, and we do a SNAPS audit biannually to yearly as well. We follow all the guidelines that are set out from the NAPS audit. So for us, as a small site of less than 100 beds, we do a point prevalence survey over 2 different days, usually 1 to 2 weeks apart. And the reason for that is we just wouldn't have those antimicrobial script numbers that would be required for a robust audit. Even with the 2 days, we generally get about 40 to 50 antimicrobial prescriptions to audit. The SNAPS is a retrospective audit on the surgeries in a defined period. So we do conduct that as needed twice a year. And most of these audits are conducted by our pharmacy department. So we get our students involved, medical students as well, to help us out as we are a small team. The guideline compliance and appropriateness is determined by a pharmacist. That's usually myself in this role, with assistance from the QSAMPs team for external validation. So they really help me ensure that how I've rated the appropriateness is actually correct, and they will get the ID doctor to have input if needed as well. So I will say that it is an almost entirely paper-based health service here. So that can make it really slow to audit. So that's just something that we have to be very mindful of. So closing the loop in a small place. So why is feedback essential for us here? So for us, it's turning that audit data into action. So it helps us come up with some tangible QI projects from the audit data. It helps close that loop between audit and practice. Assists in driving behaviour change and improvement. It enables us to reinforce those good prescribing habits when we do see them. And most importantly, it's building trust and engagement in a small team. And that's especially important in a rural and remote area, as we all work so closely together to achieve outcomes. So that one's really important for us, that we have a really good feedback culture here in our small health service. However, obviously, we're going to have some challenges on the red ground out here in the northwest. As mentioned, we're a really small team with no dedicated staff employed solely for AMS activities. So you really need sufficient time to conduct the audit and provide the feedback, other competing duties. So there's limited time maybe to have those feedback conversations. We also have a lot of local medical officers that come into the health service that are unfamiliar with our local AMS procedures and the common infectious diseases in the area. As I mentioned, we don't have an infectious disease or AMS doctor on site to provide that leadership and expertise, which you would commonly have in those larger metropolitan areas. We do only collect data generally for the naps and snaps at Mount Isa Hospital, and that's because of resources and not at those really smaller hospitals that we have in the health service. And so they may not feel the significance of the results to their area. Lack of engagement or interest from staff, and I think this is probably not unique to a rural and remote health service. This is probably could be in a metropolitan area as well, but it's definitely a factor and a challenge. And as mentioned, our high staff turnover and lack of continuity can really be an issue as well. So if you're sort of doing the audit and doing that feedback, if you then have someone leave, that can be really difficult as well to continue on with that feedback loop. So what have we tried in the feedback arena out here? And it didn't work for us. So firstly, for SNAP, it was conducting one audit per year with no focus area. We really didn't have meaningful data due to our low patient numbers for each surgical group, and therefore it was difficult to determine exactly which area should be made a priority. And you could say, well, why not extend the time frame so you capture more surgeries? And that's because we just don't have that clinician power to conduct an audit over several months, as we're paper-based, which makes that data collection really time-consuming. The next one for us is only presenting the NAPS or SNAPS data in a report and or via ground rounds. We know that it's necessary, but probably, as Denise was mentioning, having one intervention isn't sufficient for enacting that change, and also for reaching all of our staff as well in those different sites and all of our locums that come through as well. So what do we actually do up here to give feedback after our audits? Now, this is a busy slide and I do apologise, but it probably emphasises just how busy we are trying to reach all the key stakeholders in the health service to promote AMS. So firstly, we do targeted email or a sit-down face-to-face conversation with the clinical directors in their area where a trend has been identified. So for example, we noticed that there was a lot of unusual prescribing patterns for surgical prophylaxis and obstetrics and gynecology out here. So I met with the director in that area and we had a face-to-face conversation, which was really productive. We include pharmacy and lots of medical education on safe prescribing. So we've worked really hard this year to get involved in medical education and to be at the forefront of that. And we always include NAPS and SNAPS and AMS data in those education sessions. So even if it's a general medication safety presentation, we always have AMS included, and that helps to reach our junior clinicians. We've adjusted our grand rounds presentation to now include interesting cases and learnings from sort of each discipline rather than just the data. And we find that, you know, having a real example of why that was graded as that appropriateness has really helped with engagement from our prescribers. We also include NAPs and SNAPs and AMS into nursing education, and I think that's really important as well, not to forget our nursing staff, because they are also always there, always looking at these prescriptions, and they could feed back to clinicians if they feel empowered. We integrate AMS into orientation packages, so pharmacy is really involved in orientation of new locums, new doctors to the health service, so interns, etc. So we make sure that AMS is always in those education packages. We've also had our Q-Stamps AMS ID physicians provide the result to the clinical directors, so they have done that on site visit, or they've been able to do a virtual presentation as well to our clinical director. And we found that works really well because it's that sort of clinician to clinician conversation, and it's been really productive and had some great outcomes. We have really good buy-in from executive leadership to promote AMS from the top down. So they are really integral in encouraging our clinicians to attend the weekly AMS ward rounds and also to improve prescribing practices. And I think without that, it would be really difficult to have change and to really sort of gather all of our clinicians together. As I mentioned, we do develop reports as well, but it's not our only method, but we still do disseminate those through the standard committees. And I think the most important thing for us is it's producing quality improvement activities from the results. So for 2024, we noticed that there was some unusual prescribing of vancomycin happening within the health service. Obviously, we have really high rates of MRSA, so we use a lot of vancomycin. And for us, it then led to another QI project on vancomycin prescribing, which we did with a student, and then the development of our own vancomycin procedure. That might be really small, but for us, it does make a big change. And this year, we're redeveloping our antimicrobial reserve list and trying to make it a little bit more robust for our prescribers, especially those locums that come, so that they can really see how we want our antimicrobials to be prescribed and considered in the health service. And we hope that that will make a big change as well. And as I mentioned, always including in our education events. Last year as well, to ensure that we were an effective AMS subcommittee, we did increase our frequency of meeting from quarterly to bi-monthly, just to really get all of our key clinicians that are in that committee to get involved and to start making some real change in the health service. And that really helped get AMS off the ground as well, and to come up with some of these great feedback strategies. So some key enablers for us has been that leadership buy-in from the top down. So really having our executive team and our clinical directors support us in all of these feedback methods and in our AMS practices. And celebrating small wins. I think this is so important for us, as it can sometimes feel like such an uphill battle for everyone that's involved. But in saying that, it's a really supportive group of people in these small health services, and celebrating those wins keeps everyone going. It's about persistence. So I think we, as I mentioned, are constantly trying to give that feedback, and it does require persistence to time it right and to also get it done, and also timing that feedback right. So as I mentioned, we do try and have those sit down face-to-face conversations instead of just to a whole group of people, and we found that that's really helped as well. So some insights from the front line. So what we've learnt in our audit and feedback journey out here in the Northwest is that we have to avoid audits that are not targeted. So we've changed that SNAPS audit to be more targeted to certain clinical areas, and I think that will make a big difference in us being able to identify those areas of focus. We've ensured that support from our leadership teams to drive that change. We try to integrate AMS and the results into already existing education opportunities. And I think that's really important in a small team, because we're already doing the work. So we just need to make sure that we're also delivering our AMS results in those already happening education sessions. And having passionate clinicians on the ground constantly advocating for AMS. So we really do try and recognise important days such as World Sepsis Day and our Antimicrobial Resistance Awareness Day. And I think we do a really good job of it. We're very supported by our social media teams, and it gets it out to our consumers and the wider health service, that everyone gets involved. And yeah, they're really successful days, and we're really looking forward to this year's Antimicrobial Resistance Awareness Day in November. So what could the future look like for us? So building that stronger AMS feedback culture in a remote hospital. So for us, it could be simplifying and targeting that data. So maybe undertaking more regular audits on common indications that come through, like community-acquired pneumonia or cellulitis. And maybe that might be more palatable for our locum doctors to just see that more targeted result. We also really want to focus on having more medical and nursing clinicians to lead AMS-related QI projects based on the data results. So at the moment, it's quite pharmacy heavy, our QI projects, but we would love to get our doctors and nurses involved in some. And bigger picture, ideally, we would have a dedicated FTE for AMS in the health service. And maybe if we can continue on a really successful trajectory and we can make some really great change, then potentially there could be a business case for this. So stay tuned. So from one remote health service to another, some little take-home messages. The hospital wasn't built in a day, and neither is a strong AMS culture in a rural and remote health service. It does really take persistence and constant re-engagement with your clinicians. And I think for us, that is all the time. We're constantly having to engage our clinicians, especially with a rotating door of different locums. So it's very important to be persistent. We celebrate our passionate AMS staff. They're always encouraged and supported. And I think for us, it's having those quality improvements. So I think when people can actually see a tangible outcome from the audit, it's really effective, and I think it has worked well for us, and we'll continue to look for great QI projects down the track from our latest SNAPS results for 2025 as well. So thank you, everyone. To end, would love for anyone to reach out if they have some novel and exciting methods for giving feedback that have worked for them, especially in those smaller sites that might have some similar challenges. But thank you.
Thank you so much, Alainah, for that brilliant presentation. So we've got some time for question and answer now. So if anyone has any questions, if you want to let us know, I can unmute you, or if you want to pop it into the Q&A section down the bottom. Kaz, yes?
Wow, what a fantastic morning. Denise, it's always a huge pleasure to listen to you distill out the evidence base for this, and really helps us to think about where we need to be going. And Alainah, that was incredible, not only with what you were doing and how you're doing and taking that multiple impact, but actually they're the same problems that we face in principal referral hospitals, and everything that you have done on a multi-scale level we face in our own metropolitan hospitals. So I think the thing that I took away from you is that you have created a culture where this has just become part of everyday work.
Yeah, I think it's been so important for us as that small team to, just integrate it into everything that we already do.
We do find, with the sepsis implementation work, that working with the rural regional, particularly the very small sites, were just such a joy, because it was a kind of a flat executive structure. Once you got the buy-in and the clinical champion, things happen really fast. Whereas in bigger metropolitan hospitals, you've got to go through this committee, and then you got to sign up, and you get a business case, and you've got to do that and that. And there's so many competing improvement projects that you don't, it's not an open checkbook to keep going. You sort of have to demonstrate efficacy and delivery. So just fantastic, both presentations.
And I agree, Kaz, that those strategies or those challenges are faced, or we see them being faced across lots of other hospitals. So it's not just in regional and remote areas, and actually across other topics as well for different types of, feedback interventions, targeting different problems. So it's universal, I think, many of those challenges. And so the sort of strategies that you're working through and implementing are absolutely fantastic. Commend you for them.
And just to follow up on that, Alainah, given that you've been going for a while, have you picked and you've had that visiting team coming in to help with appropriateness with the synapse. Are you at a point now when where you are actually self-sufficient, and do you need them still?
I feel like for myself, I am upskilling in that AMS area, but we do still really value their support. I think because we don't have any on-site ID physicians or that AMS FTE as well, they have become really important for us, especially in like meetings, to provide that more expert advice, I suppose. But yes, we are upskilling in our own accord, I think, but they're still really important for us.
Thank you. I've just got, so there's one question in the Q&A from Sam Kasari. Thanks, Alainah, great presentation. Was there any particular intervention you had for aged care residents visiting the hospital?
Oh, I don't. No, sorry.
No.
We don't. We actually only have one aged care facility in Mount Isa, so we're not not large on that front, but yes.
Great. Okay. I had a couple of questions actually, and Denise, you touched on it before by saying actually that the challenges and the barriers and all these issues are the same across pretty much any medical specialty, not just AMS. I was wondering actually if there was anything that seemed to be unique in the antimicrobial stewardship space in the literature that perhaps wasn't there in other medical domains.
I think the problem is a lot of these things we can't measure. So, the sort of the organisational characteristics and challenges that Alainah spoke about are very hard to actually capture and extract from those trials that have been published to date. So they're not really teased out in the literature. And I guess just in AMS in hospital settings, it's obviously, a team enterprise involving lots of different clinicians, and that may be different in, say, general practice where there's sort of, individual GPs prescribing. So perhaps there's organisational context issues that might be different, but it's not borne out in the literature per se because those characteristics are hard to measure. But I think that's something, obviously that CP fit, that theory shows those different characteristics. And I think we need to get better at actually measuring those as we do these studies.
Yeah. I had another question around, I suppose, the timeliness of feedback. And I think Alainah touched on it, saying that actually sometimes it takes a while to audit. Maybe if you're a small facility, it can take a long time to kind of get enough patients to have any meaningful results. So I wondered, I don't know, I imagine it would be better to provide quicker feedback, but actually if it is delayed, is that still all right? And then also, is it sort of better to do kind of more frequent auditing or kind of this big bang approach of having a large audit with sort of more statistically significant, so to speak, results?
We don't have any empirical data on that, the impact of the timeliness of the data or the feedback. However, we've Jamie Braho and others published a paper some years ago, and we're looking at updating this on suggestions for optimizing feedback drawn from theories and general principles and in conversation with folk who do a lot of this. And it makes sense that obviously if you're receiving timely feedback that isn't very out of date, you're more likely to perceive it as relevant and engage with it, as opposed to if it is, very old data. So in principle, it sounds like a sensible thing to do, but we don't have any empirical data to support it. The second part of your question in relation to, more the frequency of feedback, The recent review update, actually, the meta-regression showed that, increasing the frequency of feedback actually lessens the effect than compared with one-time feedback. But that's an indirect comparison. And, one of the trials that I led compared this directly in a head-to-head comparison and found that actually by providing more frequent, multiple rounds of feedback, we get slightly better effects. So the jury is a bit out there, but that was a little bit contentious in the review, in that, you would expect that multiple rounds and multiple cycles of feedback would lead to better effects. So we need to keep investigating that in some head-to-head trials.
Are there any other questions or comments? Yes,
I
Kat?
can't find the hands up thing on my.
Oh, that's okay. We could see.
Anyway, no, I think one of the things we need to celebrate in Australia is that we've had a tool for audit and feedback that's been established for 10 years, which is a standardised approach whereby really the vast swathes of at least hospitals have been trained up in undertaking in a standardised way. So we have a unique opportunity, Denise, with Radar, the CRE, to evaluate the best way, and this is one of the focuses of Misha and Denise's work within the CRE, to understand how to optimise using the NAPS feedback. And as you say, Alainah, there's a lot of value in picking off a particular condition or drug, whereby you go, okay, there seems to be this continuous blip. Let's just focus in on that. And you don't need to do hundreds, 30 patients is enough to have a pattern. So it's a very unique opportunity that we have, and the settings that we have in Australia to really deep dive, Denise, and develop that evidence base on exactly how we have to provide that information. And that comes down to those comments you're making. Is it, how effective is it going at reporting back to the executive committee versus to individual prescribers, to individual unit heads, and down we go. And how do our para-prescribers, the nurses that look after our patients, and the pharmacists that oversee it, what role do they have in receiving audit and feedback as well? Like there's many questions, I think, that are open for me.
I agree with you totally, and congratulations to you and the centre for doing all of this great work over the last decade. And I think there is power in the collective to actually move things forward and improve the impact even more. So I agree.
Yeah.
There's just, we might start wrapping up, but there is just one comment from Erin Frey from the US, just saying, thank you for this information and presentation on this important topic in AMS. I work in veterinary medicine in the US, and these issues face our hospitals as well. So she's saying she can take these messages and research back to her university veterinary hospital, as well as teaching for her students. And
just Erin, thank you. And if you are not in contact with Laura Hardefeld and our veterinary stream in NCAS, we have, just so that people are aware, we've undertaken an international Delphi study that was led by early career, mid-career researchers that have established international consensus on the concept of appropriateness across animal and human health, and that is approaching its sort of final stages now. And that's actually really exciting, mainly because over 50% of the participants in that Delphi were in a position to influence government policy. So the participants in that Delphi were quite high level in AMS. So, thank you. That's exactly right, Erin. Yes, that's good.
fantastic.
So that's great. So we're very happy to bring you into the fray, Erin, fray.
All right. So I just have a couple of things to finish up on. We have some events to promote. So we won't have our regular webinar next next month, because of course it's November and it's Antimicrobial Awareness Week, or sorry, Antimicrobial Resistance Awareness Week, I think is what it's officially called now. And so we're usually very active at NCAS around about that time. We have, so NCAS will actually be celebrating 10 years. It commenced in around about November 2015. And so we'll be having an in-person celebration event. But we are also going to be hosting a regional antimicrobial stewardship summit, which is very topical given Alainah's presentation today. That will be on Friday, the 21st of November. It will be a hybrid event. So if you're able to attend in person, we would love to see you. Otherwise, if you could only join online, the details are on the NCAS website and also on our social media, LinkedIn. If anybody has any feedback for particular topics they'd like to hear for next year's NCAS webinar series, then please shoot us an email. Let us know. We'd love to hear from you. Otherwise, we'll be back on the 17th of December for our final webinar on the topic of digital AMS. So finally, I'd love to thank so much our presenters, Professor Denise O'Connor and Alainah Oats, for their brilliant presentations. Thank you everyone for the comments and the discussion this morning. Hope you enjoy the rest of your day.
It's probably worth putting Denise's links to that.
Oh, yes. So I have, yes.
Send it out to our NAPS users.
Sure, yes. So the events, there's a few links in the chat. So the links to the Audit and Feedback toolkit is in the chat. Also the links for the International Audit and Feedback Conference is in the chat as well. And if you're interested in attending the in-person event at Monash University in Melbourne, if you could email Denise O'Connor, and her email address is also in the chat.
Maybe save all those and we'll put it into the NAPS.
We can pop it into a newsletter and to an email. Yeah. Thank you so much, everyone. Bye.